The Capital Confidential podcast is brought to you by the Times-Union, the leading newspaper in New York's capital region. Subscribe today or visit online at timesunion.com.
You want to deport an undocumented person? Start with me, because I'm an undocumented person.
How do we beat him in an election?
We will. I'm going to run against him.
I wish you would. I wish you would, Dad. I would.
There are things in here that are unobjectionable because they're not that effective. So yeah, sure, I'll vote for a distinctive license plate. Sure, why not?
Jim, you had your press conference at 4 o'clock.
You're having a press conference now?
That's
You're
right.
talking?
I'm having a press conference.
Well,
now.
is this your space here or is it public?
No, it's my space.
Oh, this is your
Don't
space.
interrupt.
Okay.
I'm David Lombardo, and this is the Capital Confidential podcast. This episode is a look back at the overhaul of the state's healthcare delivery system 13 years ago with the Berger Commission. The mission was to ensure access to care, but the headlines when they finished their work in 2006 focused on recommendations to close and merge hospitals all over the state. Mark Ustin, the former general counsel to the commission, joined the podcast to explain the circumstances that led to the commission's formation, how they crafted their prescription for New York, and the ramifications of their work. Enjoy the show. What were the conditions on the ground that led to the formation of the Berger Commission?
Sure. So there was probably two things going on at the time, but they all centered around ultimately capital. It was, you had healthcare advocates at the time saying, we have an aging infrastructure in healthcare, in particular in the hospital space, also in the nursing home space too. And we need some significant infusions of capital. And, it doesn't seem like such a big idea now as, for the last several years, the state has repeatedly made investments on the capital side. But back then, that was a novel idea. And
to have the state actually get involved? Or?
Exactly, to the state to put cash on the table, make capital investments in the form of grants.
And so they were just doing grants, or what was what were they hoping to accomplish?
Well, this was the issue ultimately. So you had the advocates saying we need money for this, and the state was saying, well, that's fine, but in return, we need something in the nature of reform. And one of the real concerns tied to the state's aging infrastructure at the time was the number of beds and the distribution of beds in hospitals and nursing homes. We had more than we needed.
And so talk to me about that capacity. Was there a general consensus that there was too many beds? Were hospitals saying this isn't the case? What was that like?
I think it was a lot like the way people talk about the state legislature. If you ask the average person on the street, they'll say, oh, the legislature is terribly corrupt. If you ask them about their own legislators, they say, oh, no, but they're good people. I think when it came to hospitals, it was similar. I think everyone said, yes, we recognize the system is overbedded, but our hospital is essential, and you shouldn't take any beds away from that one.
And was it unusual to have a commission deal with this as opposed to having the legislature take it on or the governor's office?
It was extremely unusual. And in fact, it came directly out of some discussions with some of the advocates and someone, and to this day, I don't know who had the idea first, had the idea to say, well, why don't we do something modeled on the federal military base closure commission, where the fundamental principle is you identify this panel of experts who can make a very scientific assessment about what is going to be necessary going forward and what is not necessary. You have them put together a report with a series of recommendations, and you give those recommendations the force of law.
And is the appeal for the legislature the fact that then they don't need to make the hard decisions? They can walk away and not be held responsible for whatever the commission comes up with?
I don't think they would put it that way, but I think that is absolutely one of the things that one of the factors I think that went into the determination to go in this direction, and certainly one of the factors that drove the decision making going forward.
And my understanding is that the commission, as it was constructed, its recommendation would be law as long as the legislature didn't take actions to, subvert it, essentially, right?
Yeah, it was constructed very carefully, and it was really, to this day, one of the more interesting bill negotiations I was involved in. I actually helped to write the legislation. I can't take sole credit for it.
And you were in the Senate
governor's
at the time, or the
counsel's
governor's
office. And the language, this was in connection with the 2005-06 budget.
When did that get passed?
It was actually close to on time,
Wow.
if not actually on time. They had already started getting on time at that point.
Throwback. Okay.
Yeah, right, yeah. And before that, I mean, it had been, months and months
Right.
late. But this was something that was negotiated actually by the health chairs in both houses,
Okay.
one in the morning sitting with Senator Hannan and Assemblyman Gottfried and working out the details. And it was, at the end of the day, we built this structure that was intended really to make sure that, while we did create, something that was more or less locked in, the recommendations would have the force of law. The legislature had the ability to ultimately reject it, but the legislature, if they rejected it, had to reject it in its entirety. They weren't allowed to pick and choose. And it was also very carefully structured to ensure the maximum amount of input from all the stakeholders. Not only did you have the commission itself at sort of the top of the pyramid, but you had a series of regional advisory committees.
Yeah, can you talk about, there were 6 regions?
Yes.
And what was the structure? What were they hoping to get from each region? How did that work?
Well, the theory is, obviously, it's a very large and complicated system.
Healthcare, yeah.
Right. And the other dynamic you had is, keep in mind that Governor Pataki had already indicated that he was not running for re-election. And also at the time, there was federal money on the table. The federal government had promised $1.5 billion in return for reform efforts on our level, again, which nowadays is a very common concept and is done with much higher dollar numbers attached. But back then, $1.5 billion was a lot of money, and so there was a timing issue there too. So all of this really had to be accomplished within about 1.5 years. So the recognition there was that a lot of very difficult and very complicated decisions had to be made in a short amount of time. So we need the most detailed knowledge we can get as quickly as possible. So the thought was, if you had it all being run through one set of people, 20 or so people, that's an awful lot of work for just that group of people. And then with a staff of whatever it was, it ended up being about 10 at the end of the day.
And you were general counsel?
I was general counsel and deputy director.
Gotcha.
So the thought was, though, okay, we need some more capacity here. So, particularly, all healthcare, like all politics, is regional. So we needed people who knew their regions intimately and people who knew something about healthcare in those regions, too. The thought was to create this structure where we had these series of regional advisory committees with people who understood their areas. And
was there a fight to get people on? Were unions clamoring, hospitals were clamoring, or how were spots picked out?
This ended up being one of the most interesting parts of this. And I'll be honest, when it was first created, I assumed at the commission level you would see the usual suspects. You'd see someone from Haney's on it. You'd see someone from the nursing home associations on it. You'd see 1199 on it. When they made appointments, and not just the governor, but everyone who had appointments, and that includes both the Senate and Assembly, made a very conscious effort to take people from outside the usual political circles, and people who were more sort of industry focused and more on the ground. Yes, there was, there were people who very much wanted to be appointed. But the really interesting thing is, at the end of the day, the folks who were appointed, were not the usual suspects, and so it allowed for a very free-ranging conversation.
Does Stephen Berger, the chair, fit the mold of the unusual suspect?
Yes,
unusual suspect.
Yeah, and Steve, I should say, I said before that I'm not sure who came up with the federal base closure analogy. He's never said it, but that was probably Steve. Steve is a perfect example. Someone who is not in government now, was not in government then, had his origins in government. He was very involved with the New York City turnaround efforts in the 70s.
Financial crisis,
right? Exactly. But was someone who throughout all those decades has maintained a strong interest in policy and in particular had gravitated toward healthcare policy, but very much an outsider. And for anyone who knows Steve, someone who is not afraid to say controversial things. Like, there's too many hospitals and we have to close some, which was, something that, people are not necessarily going to react well to, but nonetheless true.
Because he didn't have skin in the game, so he could take
Exactly.
a very neutral look at things and just came up with that.
Right.
Okay. And what are the local regions doing? Are they holding hearings at the time? Are they just meeting with people? What are they doing?
They were charged with holding hearings, and we made sure to make sure some of the actual commission members were there at each hearing, and the staff were at each hearing too. And we had many across the state. I don't remember the exact number, but probably are in the area of around 20 hearings across the state.
And my understanding is there was sort of a rating system for facilities, and was that done just so you could again include an objective measurement and just proceed, I guess, without getting too much subjectivity into everything?
There was a lot of data that went into this. So the rating system you're talking about is probably what we called the first cut, which didn't make any decisions, but basically took 6 factors, assigned each hospital in the state literally a +1, 0, or a -1 based on that factor.
Okay.
And then rated them at the end of the day. And nothing, that if you got like a -6, that didn't mean you were going to close, but that is one of the data points that went into the discussions at the regional level and with the commission itself.
And was there a lot of work going on behind the scenes? Were you guys getting pressure from lobbyists and special interests who were trying to sway the process, or?
That was why we existed. And I've gotten this question a few times over the years. Well, who was trying to impact your decision making and what was going on? And
Todd Howe got in there anyway?
No, never. That was before his period, I think.
Yeah.
So we were there precisely for the purpose of sort of fielding these inquiries, and we were there so that facilities had a resource where they could make their best argument, and all of that information was relayed to the commission members too. And in fact, I will say some of the most successful recommendations that were made were ultimately voluntary. About 1/3 of the recommendations ultimately were voluntary, where facilities came to us and said, here's what we want to do.
Well, I guess that's a good point. So to turn to what the commission came up with. What were the recommendations regarding patient beds, regarding facilities, and then we'll talk about some of the non-binding policy recommendations as well.
Sure. Up until now, I've talked about closure because that was probably the most controversial element of what we did, but we always preferred to refer to it as right sizing. And
I bet you did.
Right. Well, not even just for political reasons, but because really that's what we were talking about. So it's not, the problem with the system wasn't just overbedding, wasn't just that we had too many beds. Even in situations where we had the right amount of beds, they may have been split among multiple facilities who were all in this kind of death match. And sometimes competition is good. Sometimes competition makes the competitors more efficient and drives down costs. That tends not to be the case in healthcare. So effectively, if you had a town that really only needed one hospital and it had 2, what that meant is you duplicated services unnecessarily. Those hospitals each had the incentive to maximize the amount of services they were providing, each service provision, of course, costing the system money. And at the end of the day, one of the things that is axiomatic in healthcare is, the more you do of a service, the better you are at it. So each, facility was doing, half of what they should have been doing, and that impacts quality too. Many of our recommendations, particularly the voluntary ones, is no one voluntarily came in and said, I really want to close, can you help me do that?
Right.
But lots came in and said, look, our 2 hospitals recognize that we're not both necessary, we want to work together, and here's how we propose to do it. And in many cases, that worked out quite nicely.
So there were a bunch of mergers as
Mergers,
well?
very much.
And I guess maybe we should have touched on this earlier, but why did the state have the ability to shut a hospital? Well, why can the state come in and tell a private business you're not going to operate anymore? Where does that power stem from?
Licensure. So obviously, any facility that provides healthcare in New York State does so pursuant to a license granted by the state. And long before the Berger Commission, there was a statute on the books that said the state had the power to revoke a hospital license for lack of public need. And in fact, that had been done in at least one instance in recent history. And so that power existed. there was a recognition, I think, that we had the power to do it, so why don't you come in and help us do it in a rational way? And that really, at the end of the day, was the whole rationale behind the commission.
And what was the reaction to the recommendations, especially the closures and mergers?
There, it varied. I think, again, on a system-wide basis, I think a lot of people said, yes, this is exactly the sort of thing we need. I think, when it came to some of the closures, I would say most of the closures, I think people recognize that this is not terribly surprising that this hospital was on the list. But individual facilities, of course, would fight against it. There was a series of bills that attempted to undo the effort, for specific facilities.
And were those successful?
No.
Because they had to do everything. They couldn't just pick and choose, like you said.
Right, and even after the fact, the federal money was still tied to it. So it's, you have to walk away from $1.5 billion if you're going to undo it.
Well, because I saw, I was reading some old press releases from Robin Schimminger, an assemblyman from Western New York out in the Buffalo area, and he was talking about how him and former Senator George Maziarz were going to lead a campaign to save DeGraff Memorial Hospital. And then, they have a note in the end of the press release, well, we know it's kind of an uphill battle. Were you seeing a lot of local assembly members and senators trying to launch their own little campaigns, I guess, for their own local fiefdoms?
Sure. I wouldn't say a lot, but they were absolutely there, and we watched those very closely. We also saw litigation.
Really?
For the most part, that was not successful. I think there was one out in the western part of the state that was. But for the most part, and I was happy to see this, our structure, sustained judicial scrutiny.
So how successful do you think the recommendations were for the commission? I noticed one of the findings was that it was going to save, I think, $800 million annually, and over 10 years, $8 billion. So, were there savings? Was there more efficient patient care? Services improved?
Yeah, I mean, you could chart the commission's success both in the extent to which, particular recommendations were implemented or were not implemented. I'm not sure anyone has ever gone through and sort of, checked off the dollars. And obviously in some cases that would be more difficult than others because you won't necessarily be able to say this is directly related to
especially with the Affordable Care Act getting enacted a few years later and the whole structure kind of getting changed.
Absolutely. But I will say that I think the major impact over time was that it changed the terms of the debate. Prior to the Berger Commission, I think, there was less scrutiny on the development of new services in the state.
What do you mean by that?
So, there is, we have a certificate of need system where any service that is going to be established requires approval from the Department of Health, and in most cases, when you're talking about establishment, in all cases really, when you're talking about establishment, what was then the Public Health Council is now the Public Health and Health Planning Council. So there are hurdles that have to be jumped in order to say, open a new hospital. But I think, in terms of culture, I think there was less willingness to say, wait a minute, do we really need this? While, the Berger Commission, I think, changed the terms of the debate by saying, the burden really is on the applicant to say why this is necessary. We're not going to assume public need. We're going to really enforce our need methodologies in a way that we hadn't before, and I think you saw that for a very long time. I'm not sure of the extent to which that continues to be the case.
Well, yeah. So, in the Capital Region alone, we have a lot of urgent care facilities that are popping up. Do you think they're getting the same sort of scrutiny that you'd like to see regarding the certificate of needs?
I don't think they're getting the same kind of scrutiny at this point. I think there will come a time when people start to say, this is something we need to look more closely at.
Berger Commission 2, First Blood or something.
Yeah, right. Well, there's already been, so this is an ongoing debate. People refer to the Berger Commission as Berger 1, and then he did something for Brooklyn, specifically that they call Berger 2. Oh. I argue that, in fact, our Berger Commission was Berger 2 because Berger had already led a work group that really pointed to some policy issues beforehand. It has a great report out that is honestly still applicable to a great extent today.
Gotcha. And do you feel like there's any unfinished business from the Berger Commission? Anything that you guys had hoped to get done that just wasn't realized in the aftermath?
Sure. Well, Berger himself, throughout the process, said, all this regulation of supply is good, but it is meaningless if we don't talk about reimbursement.
Okay.
And the interesting thing is the state has gone on to talk about reimbursement in the form of the Delivery System Reform Incentive Payment Program, which has a very familiar structure, right? It's the federal government promised billions of dollars in return for reform efforts to be done on the state level. And there's a very strong focus on consolidating incentives. So our recommendations for mergers, were intended to ensure that providers in the same service area shared incentives in terms of serving their population. And what DSRIP has required is the formation of these performing provider systems, across silos. So, hospitals and long-term care and primary care and a whole variety of community-based organizations all essentially jump into the same pot together and share patients, and they are accountable as a group for how those patients do long term. So they all have the same incentives.
And the patient bed situation, was that addressed by the Berger Commission? Do the findings and the closings and the mergers, do we have less empty beds now? Are we using the space more efficiently, or does it still need to be looked at?
It's an ongoing issue. We certainly did reduce bed capacity, and more specifically reduce unnecessary bed capacity. Did we solve the problem then? No, by no means. But I don't think anyone thought that it would be a final solution. I think it's an ongoing issue.
And what was the whole experience like for you? I mean, what were you doing behind the scenes during this period, and I guess in front of the scenes too?
Sure, it was incredibly exciting because the staff was a group of very dedicated people. It was our job to help balance all these interests, make sure everyone had a fair opportunity. It was this wonderful combination of, really wonky policy discussions and,
nerds nerding out.
Exactly. And on top of that, real serious political considerations too.
It seems like you're actually, instead of having a philosophical debate about things, you actually got to, really play with the toys themselves and get to do things.
That was exactly right.
And how long did this period last where the commission was in operation?
So the legislation was passed in April of 2005. It really got going. Appointments had to be made. It really probably didn't get going until August of 2005.
Okay.
And the report came out in December of 2016.
It's 2006.
2006, yeah.
Okay,
sorry.
so are you just going nonstop for 15 months then?
Yes.
And
just traveling around the state. One of our jobs was to make sure people understood what the commission was.
Mm-hmm.
So we were all sort of charged with going to these remote corners of the state and trying to explain. I can remember at one point addressing a county legislature, which shall remain nameless, but
okay.
I literally there were people that by the end were kind of asleep. Because, people can only take so much healthcare wonkiness, I think.
Yeah. And so then Governor Spitzer comes in, right after the reports comes out with his recommendations, and did he buy into this? Did he, help implement it, or was he resistant?
That is the other half of the story, which was really fascinating. And as the process started, a reasonable observer could say, "Oh, this is never going to work." And even after the report came out, a good report, but it's never going to be implemented. I will say, I was not involved really in the implementation. I left shortly after the report came out.
Because there was a transition of power.
Exactly. And I will say, the Governor Pataki had reached out to then Attorney General Spitzer at the front end, to talk to him about the process. So he was aware of it as it developed, and
he wasn't betting his money on FASO.
No, I don't think so.
So he had been
although I will
briefing-
say, John Faso was very well aware of the process too.
Gotcha.
Covering all bases.
Gotcha. Just in case.
You're right. But so interestingly, I think he conceptually bought into it, and the individuals, ultimately the Department of Health, who were primarily responsible for implementing it, I think also very much bought into it, and it was great to see. They had numerous opportunities to decline to implement, and in
They could
every
have
case.
sabotaged it.
Yeah, exactly, very easily, and they stuck to their guns, and it was very impressive.
So we're 12 years since then. Is there? When we talked about urgent care facilities, we talked about some unfinished business. Do we need another Berger Commission? Do we need somebody to put something together? And if so, what should it be looking at?
It's interesting. I think there are periodically efforts like this, both in healthcare and outside. I mean, for a while, there was a period where I think people saw what the Berger Commission did, and there was a series of proposals to handle difficult issues by giving them to a blue ribbon panel that had power to do
Governor
something.
loves commissions.
Right. But at the end of the day, something like that really requires the right environment in which to be successful.
Seems like it needs buy-in from the legislature.
Needs buy-in from the legislature. Putting money behind it is very helpful. There is a point at which, legislators, policymakers in general, remain accountable no matter what. And sometimes I would argue, you don't necessarily want to push that off to someone else because you're the one who has to answer for it at the end of the day.
And do you think anyone's going to be answering for some of these remaining issues in the near future, or are they going to kind of go unaddressed?
I think, if anything, the system is more in flux now than it was then, to a great extent because of changes on the federal level. We're working that out. I mean, New York was ahead of the curve, ahead of the Affordable Care Act. A lot of the principles within the Affordable Care Act were principles that we were already pursuing and attempting to implement. I think New York has done a better job than many other states in implementing the Affordable Care Act. And, as the healthcare system on the federal level is, if anything, even more in flux now, I think New York has done a good job of trying to chart a course that keeps it moving in the right direction. And I will say, I do think it is moving in the right direction. I think, there's going to continue to be stress, and the stress comes from two things, both stress in affecting change and stress because, these kind of changes can be very complicated, very hard to understand, and if you don't make a career out of this stuff, sometimes it's incomprehensible.
Well, that's a good enough place for me to leave it, Mark. I really appreciate you taking the time with this walk down memory lane, and thanks for joining me.
Glad to be here.
And that's our show. My thanks to Mark Ustin for joining me on this walk down memory lane. Keep up with all of the Capitol Confidential work by following us on Twitter at TUCapCon and by liking the Capitol Confidential Facebook page. And you can connect with us on all of our social media platforms. Let us know what you like about the show, what you like a little less, and what you want to hear in the future. Until next time, podcast adjourned.
Just heard I tried to get you.
This day sucks.